Hi. Hello, everyone. Welcome to my live stream Q&A for December. I hope everyone is well. And, I'm going to check my comments to make sure that's open. So if you are sending me any messages, I'll be able to see them. And generally, I try to do a couple of these live Q&As in a month, but since we're in December, I thought, people are busy with holiday plans, so we'll just have this one and then we'll regroup again next year for more Q&As. And in the meantime, just want to remind people to check out my website, vyvyanelohmd.com, vyvyanelohm.com, and subscribe not only to my channel on YouTube or podcast if you haven't already, but also to the newsletter that you will find on my website. And in the newsletter, I usually give people a heads up on, what's coming ahead in terms of podcast episodes. Also, I just filmed an episode, and there's something I referenced in the episode that I will put in the newsletter as well. I tend to send those out once a month, so I don't have that much time. So once a month, I think, is about good for me, and I don't want to flood people's email boxes either. So I just update that once a month. So I hope you'll subscribe. And in the meantime, if you have comments for me, I think some of you have noticed that I have been making episodes based on your requests. So whatever you asked me to do, I'm trying to, check off my list, go down the list and make sure I do those episodes. So just to, let me know what else you might be interested in hearing. The one that I did most recently on advanced glycation end products. That one I actually didn't plan to do, but I ended up, seeing a lot of discussion on that and decided I'll just throw an episode in just to see if people would find that helpful. Okay, anyone there wants to say hi or ask a question or, maybe tell me what you think about advanced glycation end products, let me know. And I did mention that I would be talking also or giving some tips on how to stay low carb because, obviously I've done this for a long time, and I'm just going to give you some perspectives as a clinician who's been taking care of patients and trying to have them keep a low carb lifestyle. All right. So maybe I'll start with those right now. The number one tip for the low carb lifestyle is that I tell for my patients, and I hope you find it helpful, or if you are coaching clients or taking care of patients, you might find it helpful. Certainly for me, having them be consistent with logging what they're eating, especially if they hit a plateau, especially if they get to a point where, they're not doing as well as you might imagine, and then you're scratching your head, they're scratching their heads, and at that point, I usually will tell the patient, "Why don't you keep uh, a really accurate log?" And people will say, "I eat the same thing. I know what I do." And I always say, just keep a log, a really good log for the next 2 weeks. Okay. So I get them to keep that log. And a lot of times patients are, not willing to log what they are eating because they are embarrassed. And there's a lot of shame around their eating habits. That's something I find to be quite common. So for those patients, what we do is we tell them, then keep a secret log. It's just for you. It's not for us. We don't have to see it. So right now they're using an app that we can see in real time. So they take a picture and we know, we can see it in real time. But when they're in that position where they're not comfortable logging, because I know deep down they feel like, oh, what will Dr. Low think, or what will her team think, right? So I tell them, just keep a secret log, keep a little notebook, but write down every little thing that you eat. And every time that the patient has actually done that, miracles have happened. Okay. So I'll tell you, just one patient where she was like, oh, nothing works. I'm doing everything you tell me. It just doesn't work anymore. And I said, do me a favor, would you just keep a log? Oh, that doesn't, I eat the same thing. I know what I'm eating. I'm like, just do me a favor. Just log. All right. And hi, Tony. Good to see you. All right. Oh, yeah. Okay. I will be talking about that. So I tell them to log, and so this woman, she did. She kept the log for 2 weeks. She came back. We didn't have to have a discussion when she came back, because 2 weeks later she had lost 6 pounds, and all she did was log. I told her, don't even send me the logs. Don't even, just write it down for yourself. And she logged it, and she lost 6 pounds. So we didn't really even have to talk after that. I was like, miracles happen when you log accurately. So what inspired me to start sharing via YouTube? Well, Tony, I think you have the same experience of how we're trying to get this message out, and it's it's been a push, hasn't it? I mean, to some extent, it has grown this movement where people realize that lifestyle habits make a huge impact on their lives and their health, but it's still a long way from where it needs to be, and especially in the, I think, provider community. Tony, you're a doctor, you see patients, and I don't know what's your experience, because I find sometimes that it's easier to get my patients on board than other providers. I'm not asking people to just take my word for it. I try to send them information, articles, and but it seems like there's still a little bit sometimes of a wall there. And so doing the YouTube channel for me was my way to provide some education, not only for patients, but people who are taking care of patients, right? Because we're not taught in med school. And I just had a conversation with a med student. She's second year, Maya, who is going to start helping me as an intern for the podcast. Anyway, I asked Maya, "Are they teaching you any of this?" And she's like, "No, none of it." And she says, and it's basically the same as when I was in med school. You memorize a bunch of stuff. You don't quite know the implications, especially in biochemistry, and you don't quite know why you need to know this, and there's no link to actual patient care or patient cases. So it seems like this information that you just have to know and pass the exam, and then you go on to the real stuff in medicine, which is, mostly learning about meds and so forth. And that's important. But I'm finding that that's still the way it's being taught. So I decided that I wanted to provide a different perspective, and for patients, obviously, but definitely also for providers, coaches, people who are working, with patients and clients. Um, oh, okay. Yeah, you said you started your podcast and you couldn't get anyone to use the podcast app. So yeah, that's exactly it. Having the videos I just mentioned in the last episode, right? I could refer patients, and especially when you have providers that nowadays it's 10 minutes per patient visit, and they cram all the patients in, and a big frustration is they don't have the time to do any meaningful education. So hopefully that would be a way to provide a resource for doctors, and other providers who just want their patients to get that information. So yeah, that's another um, big push for why I'm doing it. But whew, it's taking up a lot of time. So, I mean, I don't know how you do it, because you're pretty active as well. So how are you, managing your time with it? because I'm doing it like at night and on weekends, and sometimes I'm just so pooped, I'm really tired. I made an episode last night, and then when I watched it again, I realized I was just pretty much falling asleep, so I had to retape it today. So I don't know how you do it because you've been doing it for a very long time, right? Um, anyway, I'm so I'm so pleased that you're here. It's so nice to have your support, Tony. I really appreciate it. So thank you very much. And logging, yeah, meters don't lie. This is true. Uh, and wouldn't it be great if we could give everyone CGMs, right? That was a conversation I had with patients, I think, and they were very curious and they want to know too. And I think it would be a great idea because uh, people should know what's happening when they eat certain foods. And there's no arguing, like you said, with the data. Yeah. Whatever you think you did, the meter will tell you. And it's funny how we always talk about personalized medicine, precision medicine, right? And we're not willing to look at individual data, right? So it makes no sense to me if we're going down the route of personalized medicine. Why aren't we letting people have CGMs? I think the insurance companies should just say, look, we'll let you have the CGMs, and if you keep your blood sugar within a certain range for the whole year, we'll reimburse you, or we'll give you some, we'll pay for the whole thing, whatever. I mean, that would be an incentive, and it would get people healthier at the same time. So I'm not really sure what the resistance is to that. So, you know, I find that getting people to prick themselves, not really compelling for some of these patients. They don't like, kind of sticking themselves that often. But if they were just wearing a meter, and it's anything that takes away any of the friction for collecting data in any way, I think it makes it a lot easier for people to actually use. So yeah, so that's a one important thing that I find is really useful if you're trying to keep a low carb lifestyle and you hit a wall. The logging is important, or keeping, looking at your meter and paying attention to the data. The other thing, and Tony, I wonder what your opinion on this is. I just find that too many practitioners give this advice of doing things in moderation, right? So there's this general way of counseling patients, especially for nutrition. They'll go, well, you need to eat healthy, whatever healthy means. You need to eat healthy, but yeah, once in a while you can have X, Y, Z. You can do this in moderation. And I'm like, okay, you clearly have not taken care of patients, because if patients could do it in moderation, they wouldn't be seeing you, right? They've already already tried to do it in moderation and it hasn't worked. So I wish we would just stop telling people that you can just do it once in a while, every now and then, because that has never worked. And I think that's bad advice. Um, oh, you use interviews and the guests do the work. I'm definitely taking that route. So I'm looking for, and I have some in mind. So definitely, I think that will be helpful because, yeah, generating all the material yourself. Most of the time, it's stuff I've been teaching my patients, but sometimes, a new topic comes up or there's new information, and doing that research and making sure you're up to date. That does get a lot of your time sucked up. Hi, Tieli. How are you? Does intermittent fasting help increase insulin sensitivity? Yeah, fasting in any form will increase your insulin sensitivity. It does. My issue with intermittent fasting is that we're looking only at one aspect of a patient's metabolic health, right? With intermittent fasting, you're only looking at weight and, BMI, whatever. But we're really aside from that, and it's my same problem with medications, right? Oh, we want the patient to lose weight. So we'll put on this medication, you do intermittent fasting, you lose the weight, and that's great. And intermittent fasting, okay, there's autophagy and all the other great stuff that's related to it. But in addition, you have to look at the patient, right? My patient population tends to be older, and therefore, these people are already struggling with keeping on muscle mass, and they are struggling to build any muscle. Okay. So they have anabolic resistance in terms of keeping muscle on. So in that case, that intermittent fasting is not helping because there's no way you can get enough of the proteins in the right way over the course of 24 hours, right? I mean, people say, oh, you recycle the amino acids. Well, okay, that's great, but I need more amino acids because I want to build more muscle. Where's that coming from? Is that raining from the sky? It's not, right? You got to consume it. So yes, you can recycle, some of the amino acids, but I'm talking about, I think we need more because we're trying to build more protein in the muscle, right? In that case, the intermittent fasting is not going to be helpful. So I like intermittent fasting, but I use it as a tool for a certain time period for specific patients in a specific context. But it's not something I advise my patients to have as an ongoing lifestyle because very quickly they will lose muscle mass and then you're really down the wrong track. As you lose more muscle mass, your insulin sensitivity is going to decrease because where's the glucose going to go, right? Your biggest reservoir is going to be that muscle. And as you lose that muscle, you're you're going to actually make your insulin sensitivity worse. And this is over time. So if we're not careful with that and we're only thinking of one thing, and they do the same with the medications, right? You're only looking at weight loss. Oh, you need to lose weight. You need to lose weight. Well, yeah. It's not just the weight. Yeah. And Tony, you're saying that moderation is not logical. Yeah, these people can't stop eating the carbs once they start eating. If you've ever taken care of patients, you will know this. If you've ever really had a real patient in front of you, it's not from lack of willpower, it's not from lack of discipline. Those foods are deliberately designed to be addictive. So to tell someone, just eat it in moderation, yeah, you, that doesn't help. Um, Greatly reduce the macronutrient contents. Yep, and moderate carb content. Yep, exactly. So that's a better way to tell people. And if you tell people to eat a little every now and then, you can have this. They were trying to do every now and then, and they couldn't succeed. They kept eating more than every now and then because it's so addictive, right? So yeah, teaching them great principles of eating at the looking at the macronutrient spread, timing of meals, and so forth, and having them adhere to those principles. I think that's a lot more helpful. Um, does intermittent fasting change your LDL levels? Also, with fasting, you need to eat a lot more at each sitting, and unless one keeps carbs at a super minimum level, the carb intake at each sitting would be higher than spreading the meals in a bigger time span. Not just the carbs, Jelly. The other thing that will be at a higher level per meal because of the time constraint is the protein intake, right? And unfortunately, a lot of people still have the misconception that if you don't eat carbs, carbs are the only things that will spike insulin. And that's not true, right? We have, if you have a lot of these gluconeogenic proteins, amino acids, alanine, for example, is going to have nicely spike your your uh, your insulin, right? And so there's this misconception that only carbs will elicit an insulin spike. And that's not true. And that's why when you tell people to eat protein per meal, you have to be specific about the dose. You go too high, you're going to have a nice insulin response. Okay. And it's no um, uh, coincidence that if you were to do a real ketogenic diet, so a medical ketogenic diet, okay, you look at a medical ketogenic diet, the strictest is the 4-to-1, right? So for every 5 grams of food that you eat, 4 grams should come from fat and 1 gram from carbs and protein. They put protein. It's not just 1 gram from carb. No, 1 gram from carbs and protein. Okay. So if you had low carb, but you had high protein, you could still exceed that ratio, right? And that's because we know that excess protein will give you an insulin response. So just saying that carbs are the only macronutrients that will spike your insulin, that's not accurate, and then it's going to lead to some recommendations that are not going to be helpful to your patient, right? Or to whoever you're trying to help. So, in terms of LDL levels, you know, again, uh, people report that their lipid profiles improve with, intermittent fasting, with things like switching to a plant-based diet and so forth. And I think that our obsession with LDL, and I'm talking about the medical world, our obsession with LDL is not well founded, but there's still that insistence that we have to, keep the LDL low. I am much more concerned with your triglyceride levels, your VLDL. Um, so and with intermittent fasting you will have lower numbers of those, but you're absolutely right, it also depends on what people are doing per meal, because if they're going to prioritize a lot of carbs and a lot of processed foods, high protein dose in one meal, because again, most people doing intermittent fasting are only doing 1-2 meals a day. It's really rare to see someone do 3 meals with intermittent fasting, right? And the other thing with intermittent fasting, I keep saying, is most times if you talk to people who do intermittent fasting, they have their first meal when? Noon or afternoon. So already the clock is off, the circadian clock for feeding, right? And I mentioned in the sleep episode that really the second most important clock after your SCN is your gut and the timing of your meals. So we're already working against the clock that way, and instead of starting off earlier. And one other thing with intermittent fasting, if especially you start your first meal, at noon or afternoon, is look, you've been catabolic all night. Okay, from the time you stop eating, your last meal at night, right? So now, as you go through the night and the hours tick away, you are going to shift towards a catabolic state. And the older you are, the more impact this will have on you. All right. So, okay, so now we've gone all night, we didn't eat, and we've been catabolic, okay, for a while. But we're going to extend that catabolic window because we're going to eat at noon or 2 p.m. It's not unusual for people who do intermittent fasting to eat, at 1 or 2 o'clock in the afternoon. All right, if you're going to do that, you just way extended your catabolic window. And then how are you ever going to catch up on your muscle mass, right? But if we only care about that number on the scale, well and good. I'm sure the intermittent fasting is doing a great job, right? But if we're looking at the whole aspect of that person's metabolic health, then you should start worrying about the muscle. You really should start worrying about the muscle, because that's going to be impacting their the sarcopenia risk and so forth. Um, and Tony, yeah, you're saying protein causing insulin spikes. Persons who are insulin dependent must be careful, since short-acting insulin works so quickly that hypoglycemia can occur after eating meat as well. Yeah, I mean, and it's also well known, right? Whey protein, for example. Whey protein will give you a very quick and nice insulin spike if you do whey protein. And then you can use that for specific things. So in my patient population, someone with sarcopenia, I might want that insulin spike because I'm trying to get them to build muscle. So after a bout of resistance training, I might dose, you know, some protein, some whey protein or branch chain amino acids because I want that spike. I want a little bit of insulin right after they've done resistance training, right? But depends on the situation, depends on on the person, and the thing that we have to remember is that there isn't a cookie cutter and one person fits all. There are general recommendations. I totally agree. We can get rid of processed foods. Absolutely. That's all round. Okay, get rid of processed foods, and we don't have to eat the loads of carbs that we do. Okay, because we're again consuming way too much of carbs, and we don't even realize it, right? So I totally agree with those general principles, but then when it comes to treating an individual, you have to be very careful because everybody's going to be a little bit different. Yeah. So I really don't tend to use intermittent fasting. Sometimes with a patient with a specific condition, I might do that. But with my general patient population, and they tend to be above 30, so I already start at the 30-year-old mark because we are starting to see more of the anabolic resistance occurring in younger ages with a sedentary lifestyle, right? So as a result, I try to make sure that we don't skimp on the number of meals and the protein bolus. Is milk a healthy food to take? And if not, what is a good substitute for calcium intake? I, I really don't have anything against milk. And, I've been using dairy as a source of protein for a long time. So, I think milk is good, whole milk. I also like the brand that we like to use. I know I don't want to throw out a brand name, but it's useful to use the Fairlife brand just because the people with lactose intolerance that low and they don't add sugars to that milk. So I like the Fairlife milk. So that's generally what we have our patients do. And then so I'm assuming when you say milk, you mean dairy. And then yogurts are trickier because yogurts is sugar, sugar, sugar city in yogurts, and you really have to be careful because people will, the way they design these little packages, they look really healthy. They got little fruit pictures on them. That's supposed to be healthy, right? So, and then you look and it's like, oh, this little tub has 20 grams of sugar, and you're like, whoa, right? So I'm very careful with yogurt, and you make sure that it's a brand that doesn't add a lot of sugars. And they just have a low natural sugar count, right? So yeah, with and yogurt is also tricky because the packaging is very different from one brand to the other. So what is one serving size in one brand is very different from a serving size in another brand. So when we work with patients, it's we're very careful with yogurt because it's very hard. One cup of this is not the same as one cup of that in terms of all the macronutrient breakdown. And of course, we're interested in how much protein that person's getting. So you have to be very specific if you're working with yogurt, the brand as well. Okay, so there's no standardization, unfortunately, with that. Yeah. So I mentioned the two things. One was logging, and then not telling people that they can do things in moderation. And sometimes the first visit I have with a patient, it's just this reckoning. I sit down with them and I say, okay, everybody comes to me saying they want to learn to live a healthier lifestyle. I said, do you know what that means? And almost no one knows what that means. And I go, okay, I mean, and I totally can get it because in the medical world we don't know what that means. So why would a patient know what that means? But I say, you know what? In all likelihood, it would mean you can't have XYZ or whatever it is. Again, Okay. And they're a little taken aback. And I know they're thinking, well, you know, why not? I can have it once in a while. I'm like, well, you tried the once in a while before you came to see me, right? Because don't tell me you were thinking, I'll just eat as much ice cream as I want. I'll just eat as many Oreo cookies as I want and make myself sick. No, you weren't telling yourself that. You were telling yourself, I'll have it in moderation. I'll have it once in a while. I'll have it every now and then, just a little bite, right? That's what you're telling yourself. So you've been trying the moderation most of your life. How's it working? Not good, right? So then we got to think, if you want different results, then we have to think about, okay, what are we going to do differently? And it's going to be, it sounds like you're probably not going to have that again if you want different results, right? And that's hard for people to take. It's very hard for people to take. And it takes them sometimes months, sometimes years, sometimes they never get there, you know? But again, I'm totally honest with my patients because everyone wants a healthier lifestyle. What does that mean? Let me tell you what I think that means. Okay. Because I've been doing metabolic health for a long time. Okay. This is what I think it means from a medical perspective. All right. And then people have to make those decisions about whether it's something they're willing to do. But, I want to be healthier. It's like, okay, they generally don't know what that means. And that's your job as the person's clinician to help them, right? First, to define, help them see what it is. And secondly, to help them achieve that if that's what they want to do, you know? So, yeah, I certainly have used a lot of dairy for for my protein source. Now, again, I just put out that episode on advanced glycation end products. So, that whole thing of how about milk and cheese and all that? Doesn't that have a lot of glycation products? If you look at any any food source, the more protein. Okay, advanced glycation end products are a result of these spontaneous reactions between sugars and protein. You have a lot of sugar, you increase the likelihood of those events happening. You have a lot of protein, you increase the chance of those events happening, right? So the higher the protein load per food source, well, obviously, the higher the likelihood of an event, of a glycation event. So if you have a lot of sugar, yes, you increase the glycation events, certainly. You have a lot of protein, yes, you can increase the glycation event, right? Because those are the two things involved in a glycation event, and it's a numbers game. So, you know, um, my thing is, if you're staying away from processed foods and being smart about some of the ways you handle and cook your food and prepare your food and not use too much high heat all the time, you're probably fine. Okay. But it is a discussion that a lot of people have been having. And I just did I guess I'm giving it away, but I just did an episode, just filmed an episode on fructose, and I was planning to do something else after that, but I just saw an article that came out, and that talked about chocolate and how most of the chocolate products are contaminated with lead and cadmium. So I thought, oh, maybe I'll make an episode on that. So I don't know what you guys think. If you think that's something you want to hear about, then maybe I'll do an episode on that. I thought that was kind of interesting. And immediately after I read that article, I kind of dug around and, you know, found out that, yeah, situations may be a little worse than we think. But yeah, it's true. There's a lot of lead and cadmium. And cadmium is what you find in batteries, right? And last I checked, it's not a good idea to consume batteries. So you probably don't want any cadmium in your body either. So yeah, I might do an episode on that. And if there's anything you think would be worth me, kind of doing an episode on, let me know. And Tony, if you think there's an episode that I should make for patients, or you want providers to know, and it might be a good resource, let me know what you think, because you've been doing this for a long time and we've kind of been fighting the same fight. And it's essentially like, we certainly need to do a whole lot more education, and kind of make sure that we're all on the same page, right? Because sometimes we're talking over each other, but just making sure that everybody's on the same page and that we're giving good and consistent advice to our patients. So for example, not telling them that, oh, you don't have to worry about any other foods because carbs are the only things that spike insulin, right? That already, that's not going to be helpful, right? And we just want to make sure we get consistent information that is accurate. So, if you think of a topic that you think would be useful for me, either for patient education or clinician education, like the general PCP might find helpful or family physician might find helpful, um, please let me know. Okay. And any other questions for me? Any other, mm, comments? It's not, I'm just scrolling on the questions and comments. Hi, Maya. Recognize this? Thank you. It's keeping me warm and it's lovely. So, and Maya is a second year med student from BU, and she's really coming on as an intern to help me out with my podcast, and she's already done an amazing job, and we have a lot of very, very exciting things planned, don't we, Maya? Shh, don't tell them. But we have a lot of exciting things planned. Among those things would be, like you said, Tony, having guests. So planning a guest list, and we're working on that. But we have other exciting projects that we're working on. Insulin blood tests for insulin. Yeah, you can get fasting insulin and fasting glucose, and then you can do what they call a HOMA IR test. You can with certain labs. I use Quest, and they have generated I think, a useful tool. It's called the insulin resistance score. I like that. I like the insulin resistance score because it makes sense for the patient. See, this is more for the patient. Often I order these tests and I don't really need to know the results because I already, you just already know what it's going to show. So it's not so much for me. A lot of times the tests and the results are for the patient, right? And it needs to be meaningful to the patient. And the reason I like the insulin resistance score that the Quest labs do, that's because of the way they present the result. And they kind of give you a score from 0 to 100, and that's based on an algorithm that they've developed, looking at insulin, the C peptide, which is part of proinsulin, and they have some calculation to kind of calculate this insulin resistance score. And as I said to my patients, this is a test you don't want to score 100 in, because the higher the number, the worse your insulin resistance, right? So I tend to use that test on my patients. Most people are still using glycation to evaluate the sort of metabolic status for their patients, and they look at A1C, glycated hemoglobin A1C. You can look at glycated fructosamine as well. And that's a shorter time range. So your A1C is going to tell you your average blood sugar range for the last 3 months, and fructosamine, like the last couple of weeks. So it's a shorter range. So sometimes, I mean, I don't use it very often. Again, I tend to do those tests more for my patients than for myself, because you take one look at this stage, having done this for so long, you take one look and you kind of can guess where they're at, right? Um, but it's very handy for patients to look at the score and then have something to shoot for. If you're given a score, right, and you're scoring 100 and that's really bad, then the next time they do the test and now it's 40, then in the patient's mind, they can see progress as well. And as many ways as possible to mark progress for the patient, the better. Because, if you are only looking at the number on the scale, then yeah, that's that can put your patient in a bad place as well. So I try to, I mean, inevitably we do look at the patient's weight from week to week, but we also try to generate as many data points. So I try to look at the blood test, we look at the DEXA, right? And that way you get a better picture of the metabolic health and not one that is only focused on weight. Even at this point, I'm still having to tell people it's not about your weight, okay? For pre-diabetic people, is it useful to check glucose after each meal? I think that it's useful for most people. Tony and I were just talking about, checking your glucose, and I think it would be great if more people could wear the continuous glucose monitors. They're expensive, and you have to write a prescription for them, and blah de blah. But I really think it would be very eye-opening for most people to wear one for a couple of weeks, okay? Just to have a sense of what they are doing to their bodies when they consume something. Now, the biggest reason, I mean, you ask people about, um, you know, why it's so hard to lay off, let's say, certain foods or to stop eating certain foods. One of the things they'll tell you is, look, if I bang my head on the wall, I know it hurts, it might bleed. If I fall on the floor, I get a cut and I see the consequences immediately, right? But with the food, it's not like I keel over. Most times I'm not in pain, right? So there's no noticeable effect on their bodies, and so they're not going to pay attention. Having that meter and uh, having them register in their own minds what that food is doing, after they've consumed it to their body, right? I think when you give people that kind of input, yeah, I think it's helpful. So pre-diabetics, diabetics, obviously, but just even people who are not pre-diabetic, right? Because if you realize, oh, when I eat that, oh my god, it spiked. I didn't think it would spike my sugar like that. You're going to pay a lot more attention to what you put in your mouth, and the next time you're offered X, Y, or Z, you'll probably be thinking 5 times, right? Because you can't escape what your body is doing in response to that meal. So I really wish that we would actually liberalize, whatever that word is, the use of the CGMs, the continuous glucose monitors. Um, Let people see what they're doing to their bodies. Okay, we're happily writing these scripts. So here, have this medication. It'll make you vomit. It'll make you nauseated. But I won't give you a meter to see the effects of what you're eating on your body. It's like that to me is completely crazy. It's like, oh, they're so expensive. Well, one dose of that medication is just as expensive. So, I don't get it. So don't talk about cost to me, right? Because they're like, oh yeah, those CGMs are really expensive. Last I checked, about $700 to $1,000, and that's about the range of the price of those new weight loss medications per month. And then you're going to have to do that month after month after month after month, right? And now I'm just saying, let people wear the CGMs for 2 weeks, or a month, just so they get a sense. Ooh, okay, there's a real effect of food on my body. But yeah. And then I wonder why our healthcare system is so bad. People should just get healthier. Well, why don't you help people get healthier? So Anyway, I go off on my rant, right? Maya, any questions for me or any requests at all? I've been going down my request list. So did the fructose one and just checking off a lot of requests now, but they're all fun topics, and I definitely want to get to them. And yeah, one okay. What other tips to keep a low carb lifestyle? One that is very obvious, but nobody wants to look at is you got to cut out the alcohol. You got to cut out the alcohol. You got to cut out the alcohol, right? And yeah, no, there is no. Okay, I know there are on the market. There are keto wines. Okay, all right. I think it's great marketing. Okay, and really people also neglect the effect of alcohol on their behaviors. When you drink alcohol, you have less restraint. And everybody will tell you, if they're honest, that they had that glass, they're going to have dessert, they're going to have, a little nibble of this or that. So, yeah, no alcohol, right? Uh, oh, okay. Questions. Any tips on improving balance? It's funny, I just taught a class this week and we were working on balance with my patients. And essentially, look, balance is something where you're just going to have to practice. So I was giving them exercises that they could do. Essentially, you can just stand on one leg. And most people will find trouble just doing that for an extended period of time. So I tell people, like, if you've been working at your desk and you get up to stretch, then stand on one leg, and for half a minute, for 1 minute. Or you can take all calls on one leg. Okay, so you can take a call and a phone call or whatever, and stand on one leg. Or in your Zoom meetings, I'm standing on one leg now, can you tell? So you can be practicing your balance while you're going about your day. And then you can make it harder. So if you're balancing on one leg and you're moving any body part, and you have to maintain the balance on the one leg, it's going to be harder, right? So incorporating movement, upper body movement, for example, or changing your torso position, that will also challenge the balance a lot more. Obviously, closing your eyes is going to challenge your balance. So if you are getting good at standing on one leg, and I mean one leg, don't put the other leg on the supporting leg, because that helps. So separate both legs, okay? Yeah, I know all the ways that people cheat with the balance. So separate both legs, lift one up, but don't touch them, and then balance, right? And when that gets easy, try looking up, or looking up while you're standing on the one leg. That will get harder. And if you want to make it even harder, close your eyes. See, start to wobble a little bit more when you close your eyes, because yeah, no visual input, right? There I go. So and if you're going to do that make sure you're near a support, a wall or something that you can use as a support. So I just have people practice that a lot. And believe it or not, they improve. I have people who can't stand on one leg, timber, they're going down, right? But if they've practiced for 2, 3 weeks, suddenly they're standing up without any support and they're doing a much better job. And they can hold it for a minute or so. So balance actually comes quite quickly if you're practicing it regularly every day. The other thing for balance is, if you are thinking of movement practices, something like Tai Chi is excellent. Any dance, but also Tai Chi is very good, because you're constantly balancing on one leg, but you're also incorporating movement. So you're moving, but you're also balancing on one leg, and this challenges your balance. So balance is a big one, because people tend to lose their balance, um, that as they age, and that predisposes them to falls. So that's one aspect of um, fitness that is not emphasized enough, but we always do balance. And actually, when you're balancing it, so on Wednesday when I taught that class and we were doing exercises together on Zoom for balance, One thing I will say is that they were sore because supporting leg was working very hard, right? And they were like, oh my God, they were feeling their hips and so forth. And so if you actually properly, doing some balance exercises, you will find some muscle activation in your core, right? In your lower body as well. So you can actually get some resistance training in depending on what you're doing, which was what we were trying to do this week with our patients. So that's balance. And Maya, you asked about episode on autoimmune. Yeah, I definitely want to do a whole inflammation kind of module. So I'm thinking now more in terms of I'm building these episodes, but I'm building towards, some of the big topics. So I kind of consider them modules, right? Because there's so many aspects mm, of these big topics that we don't think about. So, as an example, a big topic that has fascinated me for a long time is something like atherosclerosis, coronary artery disease. All right. So, mostly that's always discussed in the context of what? Cholesterol, 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 cholesterol. And they throw in the lipoprotein there too. When you hear the word lipoprotein, what do you think? Cholesterol, maybe triglycerides, And I'm like, oh my God, there's so much more to it, right? And we're stuck in, I mean, like with information from 20 or 30 years ago. And if you look at the what's currently available in the knowledge base that has come out of research, we're a long way away from that, right? So it's just kind of moving along and not getting obsessed only by one aspect of a topic. It is it might well be an important aspect, but it's only still one aspect. And that's one of the things that is hard, I think, to get people to see is that your body is not acting in isolation. It is coordinating different systems, coordinating different tissue types, right? And so it's not like something actually acts in isolation and it's just this. First of all, there's so many backdoor routes and pathways, right? And there's so many types of signaling, and all of it is very context driven. And so, yeah, that may be true, but in this context only. That something else may be true, but what's the context for that? That's way more important. And we haven't gotten around to thinking about health that way. We haven't gotten around to thinking about medicine that way. We haven't gotten around to thinking about our patients and patient care that way. It's still the whole, yeah, okay, I learned this thing. And so, yeah, cholesterol. Okay, so keep the cholesterol low. Da, 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 da. And you're like, okay, but it's a lot more than that, right? So it's certainly a lot more than that. And that's what I'm hoping to kind of bring to the podcast is let's see the bigger picture, right? We're going to talk about cholesterol. Let's look at the much bigger picture. If we're going to talk about lipoproteins, there's a much bigger world than just cholesterol, right? If we're going to talk about atherosclerosis, there's so many other factors that are fascinating that never get discussed, right? So that's what I'm hoping. Is fat around the waistline an indication of visceral fat, and does liposuction? Oh, this is such a great question. Such a great question. Does liposuction reduce visceral fat, which is around organs, fat to redistribute from outside to under the skin? Okay, that is, you saved the best for last, right? Because our time is almost up. But that was the question of the night, definitely. So, um, fat around the waistline, it's hard to tell if it's purely visceral or you have some subcutaneous fat. If you are female, highly likely you have some subcutaneous fat around the waistline and you may have increased visceral fat. Now, the males I see, that is also true of males, but you're much more likely to see just visceral fat around the waistline with males. Like I have my male patients, you can't pinch that fat. You look on the DEXA, there's no subcutaneous fat. There's no subcutaneous fat. It's all visceral. Okay. So, and therefore, even if they're skinny and all the fat they have is visceral, they are the equivalent of lipodystrophic patients. These are patients with, kind of abnormal deposition of fat. So they have very little subcutaneous fat. And all the fat that they have is the sick fat that out is in organs, let's say. Okay. So a lot of my male patients, I see that, situation, but yeah, generally people have some, and then it depends on that person whether they have more or less subcutaneous. But if you see a larger waistline, you could say that there is likely to be more visceral fat. The is it IFD or IDF? It's either the International Diabetes Federation or the International Federation for Diabetes. So one of them. Anyway, they only have one criteria for metabolic syndrome, and that's waist circumference, right? So they're just looking at waist circumference, and I believe if it's greater than 40 inches for a male and greater than 35 for a female, then that's it. You have metabolic syndrome, right? So, like, that's all they care about because that to them is an approximation. But we also know, and if you look at MRIs, that it a certain waist circumference can have very different levels of subcutaneous versus visceral fat. So you can have the same waist circumference in, let's say, 5 different people, and they will have differing levels of visceral fat or subcutaneous fat. Okay, let's say the waist circumference is 35, and we're talking about men, 5 men with the same waist circumference of 35 inches, right? If you actually did a MRI cut and looked at that waist, right, you're going to find that they have very different levels of visceral fat. And so you can't actually really rely on the waist circumference. It can just give you a little bit of a hint. Now, with regards to the liposuction question, liposuction is removal of fat only from the subcutaneous region. So the fat that's under the skin can be removed by liposuction. It does not take away or touch any of the fats inside your abdominal cavity, inside your body. It's just right under the skin. Okay. Now, think about this. If you decrease the subcutaneous fat, which tends to be your healthier fat and acts as a protective buffer, then and you don't change your lifestyle, you don't change your eating habits, then the fat that you accumulate will go in directly into organs. Again, you are going to be like the person with lipodystrophy, right? They have no subcutaneous fat and they have high insulin resistance, high liver fat, right? And they're very sick. Okay, they don't do well at all. So again, the liposuction, if you remove healthy subcutaneous fat and you are not changing your lifestyle habits, then any new deposits of fat are only going to go into the organs and kind of be deposited as what we call ectopic fat, right? And also over time, if people have a lot of subcutaneous fat over time, that subcutaneous deposit can feed into the visceral deposit as well over time, especially if there is a large accumulation and it's been chronic for a long time. Okay. All right. I think we're coming up on our time. So I am so glad that all of you showed up, and I am really grateful to be able to have this time with all of you and get your questions. So I will be, I think, doing my next Q&A in January. Look out for it. In the meantime, make sure that you send me your comments. You can still contact me on my website if you have questions, and I'd be happy to answer them. Okay? All right, everyone. Thanks so much. Big hug. And thanks for joining me today. Bye.